Good morning, ladies and gentlemen. Welcome to this special Devex event coming to you live from Neuhaus, Madison Square, New York City during this special UNGA 78 week. My name is Richie Jones, Editorial Director at Devex, and together with my colleagues, I'm delighted to welcome our in-person and online audience to a discussion on how improving kidney health can transform health systems for all. First and foremost, I'd like to give a big thank you to our partners at AstraZeneca for helping to power this event. Now, just to briefly help set the scene today before welcoming our first guests, non-communicable diseases or NCDs, such as cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes, are responsible for some 41 million deaths each year. But efforts often fail to address chronic kidney disease, or CKD, a vastly underdiagnosed NCD, which is frequently caused by diabetes, hypertension, and obesity. Globally, there's more than 5 million people who die from lack of access to treatments for kidney disease each year. That's up more than 29% since 1990, and it's projected to become the 5th leading cause of death worldwide by 2040. However, many health systems around the world are unprepared and almost non-prioritize kidney health. Dialysis patients are up to 40 times more at risk of death, with cardiovascular disease responsible for up to 50% of those deaths. But still, many health services fail to recognize the close link between chronic kidney disease and other NCDs. And low and middle income countries are often hit the hardest. And the cost of kidney disease is the largest cause of catastrophic health care expenditure in LMICs, low and middle income countries. And the public health costs continue to rise. So, as global leaders gear up for this week's UN high-level meeting on universal health coverage, I think it's a timely moment to acknowledge the importance of maintaining good kidney health within the broader UHC agenda, along with NCDs such as diabetes, hypertension, and obesity. So without further ado, I'd like to welcome our first guests, Marisol Robles, president of the Mario Robles Ocio Foundation, her interpreter, Olivia, welcome. And joining us virtually from London, Professor Alistair Maguire, who's the head of department and chair of health economics at the Department of Health Policy at the London School of Economics. Yeah, that's great. So a big warm hand for our guest, please. So Marisol, Olivia, Alistair, welcome. Thanks for joining us here during UNGA 78 week. Marisol, perhaps I could start with you. Help us set the scene here. You chair the Mario Robles Ocio Foundation, named after your father, who unfortunately died of kidney failure when you were a child. You also live with a transplant yourself after spending several years on hemodialysis. Could you talk us through what you hope to achieve through the work of the foundation and the work that you do with the Alliance for Renal Health, why you feel that kidney disease needs to be higher up on the agenda, and why it's so important to work alongside other segments of the health community to really help to tackle what's becoming an overlapping problem. So I'm firing a lot at you, Marisol, but perhaps you could start with the kind of genesis of the journey.
Thanks for this invitation, Richard. Thanks for everybody here. My English is not the best. Olivia made the translation for me. I'm speaking Spanish because a lot of people in Mexico see this transmission right now. Soy paciente renal.
I'm a kidney patient.
Mi padre murió cuando yo era una niña. Tenía 7 años y ahora justo tengo 7 años de trasplante, los cumplo en unos días.
So her father died when she was 7 from kidney disease, and just now 7 years since her own transplant.
Mi cuerpo sabe cómo se siente la enfermedad renal, sabe lo que es estar en hemodiálisis y sabe lo que es estar un día en el hospital y al otro día peor que antes.
So her body has slowly begun to understand what it is like to be sick, what it's like to have kidney disease, how the body changes, and the differences she's been seeing.
Esta es la razón por la que para mí es vital hablar de enfermedad renal y volverla visible, y es una de las razones por las que estoy aquí esta mañana.
This is why she feels it's so important to talk about this, and one of the reasons why she's here, and why she thinks that kidney disease is something that is so important and needs to be talked about.
La fundación lleva el nombre de mi padre para que nadie lo olvide.
And the foundation holds the name of her father, who didn't make it.
Y así como él, yo no quiero que nadie olvide a ninguno de los pacientes que hoy nos faltan en el mundo.
And wants to make sure that no one forgets the patients that have not made it, that have not reached this point, that we continue to remember them.
Mientras estamos en este evento, una hora, morirán 2,160 personas en el mundo por enfermedad renal.
While we are at this event, in the next hour, there will be 2,160 patients that die from kidney disease.
Y es por eso que tenemos que tomar acción, y es por eso que empecé la fundación, pero esto no lo podemos hacer solos.
And that's why action is needed, but it's not something that we can do alone.
Yo estoy aquí porque tuve un trasplante internacional donde estuvo involucrado un premio Nobel de Economía.
I'm here because I had a transplant internationally at somewhere that had a award-winning program.
Mañana se cumplen 11 años de mi trasplante fallido.
And tomorrow I will reach 11 years since that's happened.
Septiembre es un mes muy intenso.
And September is a very important month for me.
Creo en las alianzas, y por eso es que empezamos la fundación y empezamos una alianza en México para la salud renal, porque solos no podemos.
I strongly believe in alliances. I think they're very important, and that's why we started our own, and that's why we've joined one, and that's why we are here today, to make sure that we can do this together, because alone it's not possible.
Creo también en el cambio de que la voz del paciente sea escuchada en estos espacios, y lo agradezco enormemente.
I'm very grateful that we have begun to listen to the patient voice, because it's a very important one, and I'm honored to be here.
No sé si quieras que siga hablando de esto.
Yeah,
Sí.
absolutely. And I mean, I think maybe just to put in a nutshell what you hope to achieve with the work of the foundation, and your key message for policymakers here this week on the eve of such important meetings here at UNGA 78. You know, what is your message to them as we start this important week for chronic kidney disease and more broadly for NCDs?
Sí, uno de los problemas es que la enfermedad renal es silenciosa. No nos vemos enfermos.
So one of the problems is that chronic kidney disease appears invisible, that it's not always shown physically when you're sick.
Lo importante es no olvidar que al final de la vida todos seremos pacientes.
It's important to not forget that at the end of life, we're all patients.
Y las decisiones que hoy tomemos van a ser en beneficio de nosotros y de nuestros hijos.
And the decisions and things that we do today will benefit us and our children later on.
Cada día que tomemos una acción en beneficio de la salud renal será algo que nos beneficiará a nosotros y a nuestra descendencia.
Every action that we take today to help patients with kidney disease is something that we'll see the benefits for years to come, for ourselves and for our future children.
Y es importante hacerlo en red, en una red creada para soportarnos, porque además la enfermedad renal es carísima.
And it's important to do it together, because kidney disease is something that is very expensive, and it's something that we need to do in unison together.
Cada año un paciente renal nos cuesta $100,000. Entonces, si toman las decisiones adecuadas, los sistemas de salud se van a ver beneficiados, la vida productiva va a ser mejor.
Every year, a kidney patient can cost around $100,000. So taking action, doing things now could save money later on, can save lives, and can save patients.
En México, particularmente, los pacientes renales somos muy jóvenes.
In Mexico, particularly, the kidney patients are very young.
Tomamos acción y te dejo la palabra.
So action, collaboration, and thank you, Marisol, for that very powerful testimony, the origin of your story. And yeah, we're inspired by your work and your presence here at UNGA 78 this week. So thank you very much for taking the time. Professor Alistair, perhaps I could come to you next. Thanks for your patience. Chronic kidney disease is projected to become the 5th leading cause of death worldwide by 2040, with a notable increase even in high-income countries. You were recently working on the Impact CKD study in the UK. I just wanted to ask why the prevalence of CKD is increasing, whether you can share any key findings from this study, and in terms of low income settings going through this epidemiological shift, what health systems should be preparing for when it comes to chronic kidney disease. Professor Alistair.
Thanks very much, Richard. Sorry I can't be there in person today, but I've got commitments back at home, I'm afraid. So you just heard about a patient's journey and a patient perspective. I'm an economist by training, and interested in global disease and healthcare systems. And I think the interest in chronic kidney disease stems partly from what you said, Richard, in terms of the prevalence globally. About 10% of the general population worldwide, that's approximately 800 million individuals, are suffering from chronic kidney disease as we speak. And I think my interest is also at the system level. So we've heard from the patient level. The system level is really, as you say, a shift towards communicable diseases globally, both in high-income and low-income countries increasingly. Unfortunately, chronic kidney disease is adding to the mortality burden within these communicable diseases. And I think that from my perspective, it gives a prime example of how we have to shift the lens. And we saw that with the COVID-19 pandemic, that really we were unprepared in terms of gearing up for preventative medicine in a way. And kidney disease, chronic kidney disease, is a prime example of where we could do more at the very early stages. There are 5 stages to chronic kidney disease, and essentially it's at stage 3 where it becomes a moderate disease for the individual, that things really start to happen. And it's been shown that if we could delay if we delay the diagnosis of stage 3 chronic kidney disease by 1 year, then that increases the progression to the later stages by something like 40%. And it also increases the risk of transplant or dialysis by about 60%. So it's very important to get in early and try to prevent progression of what is, after all, a chronic disease. So that's one reason. One reason is to try to move the lens towards progression. The second reason is essentially healthcare systems, no matter how integrated they are, and increasingly, of course, they're publicly financed for all sorts of good reasons, but that's what the Universal Healthcare Coverage UN mandate is about, trying to get more essentially public financing of healthcare, and I fully support that. But of course, if you have more integrated healthcare systems, it doesn't necessarily mean that they're coordinated. So the coordination of treating chronic disease is quite important. Moving from primary to secondary and even to tertiary care is going to be a big ask, especially in low-income countries or middle-income countries. And that's the third reason I'm interested in it, just the last third reason, Richard. I know you've got other questions, but the last third reason is essentially this is a global disease, and it's affecting the low and middle-income countries more and more, and proportionately more than high-income countries in some senses. It's affecting their growth. For example, although China and India, obviously it reflects the large population, 1/3 of all the cases of chronic kidney disease occur in China and India now, and increasingly we're seeing occurrence in lower income countries. So those are the 3 reasons I'm interested in it, prevalence being one.
Great. Thank you, Alistair, for outlining that. I know time is fairly short for this segment, but I wanted to follow up, Alistair, on some of the practical strategies and solutions that you would recommend, any coming out of the study, for example, and then briefly in the technology space, maybe some of the tools that are going to help medical professionals, particularly in resource-constrained settings in low and middle-income countries. How do we more effectively identify CKD patients? How do we identify them more efficiently and effectively?
Well, again, I increasingly I think about the healthcare sector as an insurance sector. I mean, essentially, private insurance doesn't work for all sorts of reasons, but public health insurance does work, and it works effectively. But it is an insurance, and the healthcare that's provided is the benefits to the insurance package that's given by any country. If it were left to a private insurer to do all these things, apart from it not working, but one thing that they would do is invest heavily in data. And you've got that on your slide behind you, new data. We're particularly poor at building epidemiological databases of data and patient-level linked databases across the globe. It's quite good in countries like the European countries. It's not so good even in the USA. You know, there's great data on private insurance, but then you flip to Medicare or Medicaid, public insurance, and you lose that trajectory going forward. Obviously, kidney disease is within the Medicaid package, so you see that patient journey all the way through. But we've really got to invest in data. That's one thing, and invest in data so that we can get the staging of this progressive disease correct. The second thing, of course, is that as well as investing in data, we've got to coordinate, as I said, across primary and secondary care. Because if you don't pick it up early, this disease just gets worse, and it can get worse fast once you're in the moderate stage. So coordination, data and coordination.
Thanks, Alistair. Marisol, perhaps turning back to you in terms of raising the profile of kidney disease. I understand that today, perhaps even as we speak, they are launching a global alliance for kidney health. What will the work of that alliance mean for current and future patients, as well as people living with a transplant or people on dialysis? Can you tell us any more at this stage about some of the goals and objectives of the alliance, how it will aim to address CKD challenges at scale?
Sure. First, say I agree totally with the Professor Alistair. And second, hoy anunciamos la Alianza Global de Pacientes por la Salud Renal.
Today, we're announcing the launch of the Global Patient Alliance for Kidney Health.
Y estoy muy emocionada y muy orgullosa de que esto suceda.
And I'm very proud and very excited for this to be happening.
Porque es el trabajo de más de un año de un equipo muy comprometido donde participan 17 organizaciones de más de 15 países.
And this is a joint effort from 17 different organizations from more than 15 different countries that have come together.
Y el objetivo, el más importante, es volvernos visible y que los tomadores de decisión, quien cabildea, nos escuche y vea la urgencia de hacer algo referente a la enfermedad renal crónica.
The most important thing is for us to be seen and for us to be heard when it comes to chronic kidney disease, and making sure that chronic kidney disease becomes a priority globally for policymakers everywhere.
¿Y cómo hacemos esto? Bueno, pues este es el primer paso, estar en los foros internacionales hablando de cómo esos números de los que habla todo el mundo se sienten en este cuerpo para que cada vez haya menos pacientes que tengan que vivir esto.
And how do we do this? By speaking at events such as this one and other international forums, and taking the numbers that people have talked about in studies and showing how it feels to be in a body like that with chronic kidney disease, and showing those numbers as patients.
Cuando hablamos de enfermedad renal pareciera algo abstracto, pero cuando lo sientes es distinto. A mí me gustaría preguntarles hoy al auditorio, ¿cuántos saben en cuánto está su creatinina hoy?
I would love to ask the room at large, how many know what their creatine level is currently?
We have a few
Yeah.
hands up.
I love that. Pero lo importante es que en estos países, 15 países, 17 organizaciones, y esperamos que cada vez sean más, podamos hablar el mismo idioma, the same language, with the people, con los médicos, con la gente que cabildea, para que todos entendamos la urgencia de hacer algo al respecto. Somos 850 millones. ¿Cuántos más?
We are 850 million people with chronic kidney disease across the globe. How many more people need to join that number? And so it's important that across the 17 different organizations that have joined this alliance, the more than 15 countries and the hopefully building number, that everybody, doctors, patients, advocates, learn to speak the same language together about chronic kidney disease.
Hoy visto de negro por el duelo de todos los que no están aquí.
Today, I dress in black for all those that did not make it because chronic kidney disease.
Y me gustaría que en los próximos años podamos vestir todos de colores y estar presentes más personas y más pacientes en estos espacios. Eso es lo que me gustaría en honor de mi padre y todos los que faltan y todas las organizaciones que están alrededor del mundo confiando en que esto suceda.
And in the coming years, I would love to be able to dress in color, to show the progress that we have made, and to make spaces for patients to share their stories and to share experiences like hers and like her father's.
Si quieren sumarse a la Alianza Global por los Alliance Global Patient for Kidney Health, pueden seguirnos. Hoy estará listo el sitio y pueden sumarse.
If you would like to join the Alliance or learn more about us, you can follow us at the globalkidneyalliance.org as we've launched today.
Y para hacernos visibles también existen las redes. Entonces yo les pediría que hoy usemos el hashtag Kidney Health por todos los que nos faltan y todos los que estamos en este proceso.
And I would also like to invite you to use hashtag Kidney Health as we continue this conversation on social media for those that have not made it and those that we hope to save in the future.
Thank you, Marisol. And yes, do tweet about the event or put it on LinkedIn. Have your say online in case you feel that we've missed anything in this fireside chat today. I wanted to briefly end by coming back to Professor Alistair before we end the segment. A quick call to action from you, Alistair, on as we consider this sort of key next step of reducing the burden of CKD. What should our audience here in New York and watching online take away with them and into this action-packed week of meetings here in New York?
A call for better data to highlight and increase the awareness of chronic diseases generally, but chronic kidney disease specifically, and also to try to help move the dial towards earlier treatments and earlier interventions.
Marisol, Alistair, I'm afraid that's all we've got time for, but thanks very much for your insights, your testimony, Marisol, for helping us set the scene. I'd now like to invite my colleague Jenny Lee Ravello to take the stage with her guests for our panel discussion. Thank you very much.
Thank you.
Hello. Yes. Good morning, everyone. So our panel this morning is about how good kidney health for all can transform chronic disease management and strengthen universal health coverage. I'd like to invite our panelists to the stage. Katie Zane, Chief Executive Officer of the NCD Alliance. I think we're Katie. All right. Dr. Jeff Marcus, Regional President for North America of the World Organization of Family Doctors. Dr. Slim Slama, Unit Head, NCD Disease Management Screening, Diagnosis and Treatment, NCD Department at WHO. And of course, we'll be joined virtually by Dr. Sonia Brown, Minister of State at the Ministry of Health and Wellness at Barbados. Thank you so much for joining us on this panel. Well, I'd like to start this discussion with a little bit of audience engagement. How many of you have been to at least one event this week on pandemic preparedness and response? A few hands. Okay, that's good to see. The second question is, how many of you, except for this event, have been to a panel on kidney health? Well, I'd like to say thank you very much for joining us today because this is such an important topic. This is something that's very close to my heart, and I'm really happy to be moderating this panel. I'd like to start with Katie. So, I'm hearing all the numbers, 40 times at risk of that for dialysis patients, sorry, questions are here. So CKD is often overlooked in global efforts to combat non-communicable diseases. Can you shed a light on why and why it's essential that we shouldn't be neglecting this issue when we talk about NCD prevention and management?
Thanks, Jenny. And I hope when everyone responded to that question about not necessarily going to a kidney health event, that you've all been to NCD events, which is what this agenda is all about, right? So CKD, as we've heard already from the fireside chat, is obviously a major public health crisis, an important disease in its own right. We've heard the statistics, 850 million people, that's 1 in 8 around the world. We've heard 5 million people dying from lack of access to treatment for kidney disease. That's 5 times more than HIV and AIDS and TB. And as we've heard already, it's all about the fact that chronic kidney disease is essentially an invisible disease, that people aren't actually getting diagnosed until too late, until advanced stages, which is then resulting in costly dialysis as well as transplant, which is really not available to everybody around the world in terms of the cost. It's a disease on the rise, and I think, as Professor Maguire highlighted earlier, a really important part of CKD and NCDs more broadly is the fact that this is a development issue. This is a low middle income country issue, right? It's not a high income issue that it used to be seen as. So no doubt this is a public health crisis. No doubt it's been overlooked. No doubt it needs more attention and resources going into it. But I think the important point I want to make on this one is that when it comes to CKD and NCDs, CKD is part of the family of NCDs, right? It's so connected. It's intimately connected to so many different NCDs, hypertension, diabetes, as well as the common risk factors. And you might argue, well, why isn't CKD part of the big 4 or the big 5 that WHO have historically and continue to focus on? I'll leave that one to Slim to answer. But it's part of the agenda. And, I think the important thing is that CKD can really be a pathfinder for the broader NCD response that needs to happen within health systems. And that's about shifting to a primary healthcare approach, really focusing on a chronic care model. So many health systems in LMICs are still focused essentially on acute care, needing to shift the health system to be more focused on chronic care, having a really strong focus on primary prevention. During this week at UNGA, I think the health promotion and prevention piece often gets forgotten within conversations of UHC, of pandemics. It's absolutely a fundamental aspect of the NCD response. And then, as others have already highlighted, really, really focusing on early detection and secondary prevention, because that's the way that we're going to make a difference.
Already mentioned, about the links between CKD and other NCDs, right? Cardiovascular disease is a significant risk for individuals with CKD, and it's often a leading cause of death in these cases. How can we raise awareness about the close links between, the other NCDs and CKD to improve patient outcomes and public health?
I think, when we're talking about raising awareness, I think we need to be thinking about different audiences for raising awareness, right? One of the audiences absolutely is this week. It's about policymakers, it's about governments, it's about political leaders, to be prioritizing the issue, to be investing in the issue. But it's also about healthcare professionals. How can we make sure that healthcare professionals are being trained, educated to be detecting, managing, treating these conditions effectively? And we're not here just talking about nephrologists. We're talking about diabetologists. We're talking about community health workers. It's taking the whole human resources for health and health worker approach to make sure that CKD and NCDs are integrated. And it's also about people, as we heard earlier. It's about patients. We try not to use the term patients because it's about people living with these conditions, to be clued up to the symptoms. As we said, it's invisible. We also, I think, in terms of raising awareness, absolutely need alliances. It's great to hear about the new alliance being launched today on kidney health, but we need to make sure that those alliances go beyond the kidney community and well beyond NCDs, to be making sure that we've got strong allies beyond those communities. And I think most importantly, perhaps, in terms of raising awareness, we need to be thinking of different messages for the head, the heart, and the pocket to be really resonating with all those different audiences I mentioned at the beginning. The head, and Professor Maguire mentioned the challenge of data. The head is all about making sure that we've got strong evidence and data on the epidemiology of CKD and NCDs, or whatever issue it is, to be really making the case. The heart is all about the lived experience. It's about how it's impacting so many people in this room and well beyond. And then the pocket is about the economic case. It's the investment case of why it makes sense to invest in CKD and NCDs, not just for health, not just in terms of saving lives, which is absolutely essential, but also in terms of actually driving economic gains for countries as well, which is what governments want to hear. They don't want challenges, they want solutions.
Thank you so much for that, Katie. Dr. Jeff, as the regional president for North America at the World Organization of Family Doctors, what are the main challenges you see primary healthcare is facing in terms of diagnosing and managing CKD? And how do you see the differences between high-income, low-income countries?
Yeah, I think there's two big problems, and I think I've heard a couple of the comments about both. I think people and systems. As a family doctor, my job is to take care of you as a whole person. And the truth is, the really difficult truth about NCDs is patients feel fine. When they're sick initially, they feel fine. They don't have symptoms. They aren't uncomfortable. Honestly, they don't care about whether I tell them to take their high blood pressure medicine or their diabetes medicine. It's not usually the priority in their life. They have so many other things that they're dealing with. And what we need are health systems that are able to take care of that whole person and address the entire range of problems that they present to me with. If you come to me with a headache and I treat your CKD, then you're not coming back. And I need you to come back. And so I need to be able to treat your needs while also getting you to work with me on being able to address the population-based problems, the NCDs that we know contribute to your ultimate morbidity and mortality. And the issue, I think, that I really am excited to speak here about CKDs is because I think CKD is really an exemplar NCD in terms of dealing with these issues. It's a complex problem. There's a range of NCDs that contribute to CKD itself, and there's a range of solutions for trying to deal with it. And so we really need to be able to create these integrated health systems to be able to do that. And that means we need a strong workforce, as you mentioned. We need competent providers that can really manage these complex issues and attend to the other needs of the person in front of them. We need basic diagnostics and medications that are available. When those aren't available, if we have a competent health worker, they don't have much to work with. And so again, patients aren't going to come back. And then in addition, we need effective models of care that allow us to do this coordination that Dr. Maguire talked about, to better bring together the front lines of care with the secondary and tertiary care that goes across the continuum of caring for progressive chronic kidney disease. And finally, as was mentioned, and is the prior executive director of the Primary Healthcare Performance Initiative, I'd be remiss not to mention being able to better measure these things. And that involves not only measuring diagnostics like the traditional CKD diagnostics of proteinuria, and creatinine. But we also need to be able to measure how the system actually works. And that means we need to have effective measures of frontline primary healthcare that incentivize us to invest in those things. It means being able to measure things like providing comprehensive care, providing that effective coordination of care that makes such a big difference in caring for CKD.
Just to step back a little, you mentioned about diagnostics, and I wonder, like, how available is it? How widely available is it to countries, especially low and middle income countries?
Yeah, so I have been working in supporting the development of frontline primary care around the world for a long time now. And I will say, over the 20 years that I've been doing this, I continue to show up to frontline health systems that don't have a competent provider, don't have any effective diagnostics, and have hardly any therapeutics at all. And so if you're a patient in those settings, why are you going to go there? You're not. And we really have to get a handle on how we're going to better invest in these things.
Dr. Slim, I know Katie has a question earlier, but maybe you can talk about what are the current best interventions that WHO is advising countries for the prevention of CKD among their populations.
Thank you, and let me first thank Devex and AstraZeneca for the opportunity. We have started a dialogue at the margin of the World Health Assembly. I'm very happy to see now this happening. It's at the Junga, and wanted also to mention I have no interest to declare, no financial contribution received for attending this event. Back to your question, I think as we discuss universal health coverage, most of the question from the Ministry of Health is to what Katie was mentioning. Where do we need to invest and prioritize in our bundle of services offered to the population, and how much it will cost? What would be the return of investment, both in terms of social impact and the economic benefit? So we have, since several years now, and started that exercise about assessing. There are different, groups working worldwide on priority settings for health, including, on the intervention, and the economic consideration are not the unique one, but we have developed a set and a menu of policy options, both the level of prevention, like tobacco control, packages for countries, but also in terms of management and early detection of NCDs that include core intervention that are really essential one. And they are not low-cost intervention for low-income settings. They are really very effective interventions that have shown impact and that are really a menu of intervention that all ministers in all countries should prioritize. But of course, taking into consideration the health systems constraint and the fiscal space of different countries, not all countries can invest at the same time. So this cost-effective intervention that have been updated on a regular basis now since 2013. We have the NCD Global Action Plan on NCD 2013-2030 have been extended now, and we have that menu that really lists the most cost-effective intervention both for prevention and management. This includes, and we were discussing today, of multiple silent killers. I was just 1 hour ago in the launch of the first ever report of WHO on hypertension. Just to name it, and you have a card there, you can download it. Why is it important? Because this is one part of the core essential intervention. Because to understand how we act on CKD, we need to understand of the determinant and what are the risk factors of CKD and the most common ones. Of course, there are some unknowns and data is needed, specifically in low-income settings. With climate change, there are environmental factors that we have not necessarily captured. But there are things that we know, and we should have acted yesterday. Hypertension is among them. 1.3 billion people worldwide have hypertension. A bit more than half of them, 54%, are diagnosed, and only 42% are receiving treatment. But only 1 out of 5 have hypertension controlled. And we know that this is one of the most important risk factor for the progression and the emergence of CKD as an example. Diabetes is another example. So these are those interventions that need to be prioritized in the benefit packages with financial protection, because it's not enough to list them on a policy document. People have to benefit. When I go to a primary care facility, I need to be able to get screened, to be able to be detected, and to get the medicine for treatment, and to also make sure that we can delay progression. Now, some aspects are a bit complex. There's a lot of ministries that come to us. I was 10 years in the Emerald region, the Eastern Mediterranean region. We have big countries like Pakistan, Egypt, 100 million plus population. And the ministries are asking, how do we screen? I think this is a difficult question, because when it comes to CKD, it's not like blood pressure with the semi-automated devices. You can measure it. And sometimes, depending on the blood pressure value that you get, you can even start the treatment immediately. In CKD, we can do it, but you need to measure the function of the kidney, like creatinine, as was mentioned, but also potentially the injuries to the kidney that require a urine dipstick, and we can have a small simple test. But still, there are 2 tests, and you need to repeat it at 3 months to be able to control that it's really there. So there are some elements that we need to support countries about how we do it. When we have 1/3 of the population with hypertension, about 15% of the population that have diabetes, you cannot just go out there and just screen people and everyone, because you will just break your bank. So some aspect is about targeted screening, approaches to scale up, demonstration site where you can start actually testing a system and being able to scale up. And we have in WHO developed some of the model for hypertension and diabetes that include aspects for CKD, like the HAAS technical package, that really support countries about how we prioritize, but then operationalize it at a level of primary care.
Minister Sonia Brown, CKD is on the rise in Barbados. Could you give us an overview of the current situation regarding CKD in your country?
Well, thank you so much for the invitation, and I apologize for not being able to attend. In our country, Barbados, 166 square miles, we have a population of about 280,000 people, and the population is actually decreasing because our birth rate has fallen. With respect to kidney disease, I'm basically living on extrapolations here. I got a recent study, 2020, from a doctor that did the study involving about 228 patients that are already on dialysis, hemodialysis. On island, we have over 300 people that are on both hemodialysis and peritoneal dialysis. By extrapolation of this study, we can surmise that about 7% of the population, as it stands, has chronic kidney disease. That's where we are right now. The burden lies for us is dialysis. We have come to a stage now where dialysis, yes, it is offered, but the resources are limited. So we work with both public sector, which is our tertiary care institution, and the private sector, where we have outlying dialysis units. So that takes care of a little over 300 individuals in terms of treatment. So that is a major bugbear. We are having situations now because of our protocols. We have had to decrease the number of dialysis treatments per week. So a lot of patients that sometimes deserve 3 days a week are now on 2 days a week. So these are issues that we are now facing. Patients have to be, unfortunately, turned back in some instances because of the protocols. So they're obviously made to either pay out of pocket through insurances, which is always a problem because the insurance system now covers for maybe 2-3 years and then they knock you off. So these are things that we are facing as an island with respect to chronic kidney disease.
How is it impacting, your resources specifically, and also the healthcare system?
It is impacting our resources. It stands to say, I just got the figures with respect to the percentage of our resources that we use on NCDs alone, and that equates, although it's a small island, to some 65% of our resources. To health, we allocate a little over $400 million that would involve our public hospital that is run by a board, as well as the Ministry of Health and Wellness. So 65% on NCDs alone, and I guess we can come up, we don't have an exact figure, but you would know what that means in terms of a percentage of that obviously would be on kidney disease care, but it does impact. Right now, for outsourcing our dialysis treatment, we're looking at maybe $150 US per patient for practically as long as they're living now. What we're looking at now, which will in no way make a dent into what we are facing with respect to dialysis, is making the legislation for tissue transplant. So to solidify it, has already gone through cabinet, so we're looking to go through Parliament and the Senate shortly. So that will aid in terms of getting the population adjusted to, because our culture is not with what we call cutting patients. So we have to sensitize the population in terms of kidney donation. It will in no way impact heavily on the numbers that we are seeing for dialysis, but it will obviously lead to a better quality of life for patients. You just saw the first presentation, a better quality of life for patients, but it is impacting heavily on our healthcare system financially and human resource-wise as well.
There was a lot of emphasis earlier on prevention, right? And I want to get a sense from you, like, what are you doing currently on prevention?
Okay, let me preface that by saying during the height of the COVID pandemic, a lot of our resources were shifted, like I guess a lot of other jurisdictions. So we made the emphasis more on COVID, and that resulted in us losing follow-up on a lot of patients, whether it be human resources was shifted, or basically clients to our healthcare were skeptical about attending clinics and so on because of the fear of contracting COVID. So we were under-resourced, and we're now trying to pick up in terms of putting people on the road, nurses and so on, back out on the road, and we have still not adjusted back to that. But in terms of the other issues, immunizations and so on, they're back on board. We're trying to look. So let me go back a bit. So during the COVID pandemic, we saw a lot of end-stage disease, NCDs, including kidney disease. And we are basically reeling from the effects of COVID with that. We lost not many healthcare workers, and our death rate was extremely low, which we're very proud of. But the systems have now to be in place. Our issues are obviously financial as a small island developing state, as well as the issues with climate change. People may not see that, but in our small island, we are a water-scarce country, for instance, and we are now seeing the highest temperatures that we've ever seen, and that would be over 35 degrees Celsius. So the worry now is to get the population educated on fluid intake. We have a culture here where the elderly tend to stay at home and all the windows are shut. So we have to put things in place where the nurses can visit again. We used to do it to make sure the elderly are taken care of in terms of fluid intake, and the young children. We've put out public announcements in terms of caring for young children, because dehydration has an impact on renal health. You're asking a question or shutting me up.
No, thank you so much for that insight. You mentioned about COVID, right? And Dr. Slim, maybe how you can talk about, because we have 3 high-level meetings. Well, there are a lot of meetings, these high-level meetings this week, but we have one on pandemic preparedness, we have one on UHC, we have one on TB. How do you see CKD fitting into the discussion on pandemic preparedness?
Well, I had the chance, so it was no chance, it was an obligation to respond to most of the recent emergencies beyond COVID from an NCD focal point for emergencies. So we have been involved in Ukraine, in the earthquake in Turkey and Syria, in Sudan, recently in Morocco, now in Libya as well, with the task force and with a lot of international society. And I would like to take also this opportunity to thank all the kidney community at large, of nephrologists, of the colleagues from the International Society of Nephrology, who has been extremely, helpful in supporting us. We have a task force on disaster. So one thing is preparedness. What happens when you are hit by a crisis is that it exposes the weaknesses of your system, and what pre-exists determine what you get. So if we are saying that primary health care is the foundation for emergency preparedness, we need to ensure that essential services are there at the first place. And some are basic elements at a primary care level, but also having the ability to reach out to people, to inform them, to have, the community network, to be able to say for people who are being dialysis or even those who just need oral medication, where to go, how they can get information, what are the list of contact. These are simple elements. So I think emergency preparedness discussion need to be practical, and also to make sure that for the NCD, we have a kind of common narrative. The common narrative for me is that it has been overlooked. And one of the best things that you could have done during the COVID to save more lives, because these are vulnerable population, and we know, we have documented across NCDs, these people are more vulnerable than any others to COVID, but also to all type of emergency, is to be able to maintain essential services for them. And I think this is core of the preparedness. So we have started a work in WHO across the region to make sure that NCD are an integrated part of emergency preparedness and response. So those discussions happening today and this week on UHC, on preparedness, even on tuberculosis, we have linkages, is that we should not have those narratives disconnected. They are the same, and we are not opposing one against another. We are trying to create synergies in the narrative, synergies in the action, and trying also to have a strategic vision about how the intervention can be aligned all together, and making sure that we are aligning also with a wider community responding to people's need, not the patient's need, the people's need. And I think we need those voices also to understand what is it to live with those chronic conditions, cancer, kidney disease. And I think in emergency preparedness, people are the most vulnerable among the vulnerable. I think this is something that also can resonate quite a lot here in Yunga.
Mm-hmm. You mentioned about synergies, and I want to go back to Katie. The other high-level meeting is on universal health coverage. What specifically do you want to see prioritized in that meeting happening on Thursday? And what does that mean for people living with CKD?
I think as Slim's highlighted, NCDs obviously intersect with all of the three high-level meetings happening this week, right? UHC, pandemics, TB, you can make the connections between them all. Obviously, within universal health coverage specifically, this agenda is all about making sure that people have access to the essential services they need when they need it, without risk of falling into poverty, so financial risk protection. And as we know, CKD and NCDs are basically essential challenges for many countries around the world in both of those contexts, access to essential services, as well as financial risk protection, because we know that a lot of the treatment and care for NCDs overall essentially lands on the shoulders of people. It's out-of-pocket expenditure, which is a major challenge. So moving in, going towards this UHC high-level meeting, NCD Alliance had 4 priorities, basically. Invest in NCDs more in terms of adequate, predictable, sustainable financing for NCDs. Number 2, accelerate the implementation of NCDs within UHC country benefit packages. That's where it really happens. If you've got NCD services in the country benefit packages, that will impact upon national health insurance schemes, etc. Also aligning global health priorities, because I think as we talk about a lot this week, global health is still pretty siloed. You've got the HIV/AIDS community over there, you've got the TB community, women and children's health, NCDs, but we need to be making the connections between them all, because essentially people are living with multiple conditions all at once, more than not. So it absolutely makes sense to ensure that our response is integrated and holistic. And above all, our 4th priority is about engaging people living with NCDs, making sure that UHC is essentially people-centered, that we're actually having people living with NCDs at the table, understanding what their priorities and challenges are, and making sure that the responses, the programs, the services are oriented to those challenges. I think we can have a 5-hour conversation about whether the outcome this week has actually kind of got to those 4 points, and I see we've got 17 seconds left. But I would say the silver lining of the UHC declaration is that NCDs are undoubtedly recognized more across the whole declaration than what we saw in 2019 at the first UHC declaration. And I think that is a really important step forward and will obviously benefit CKD, people living with CKD particularly.
I think, of course, that's important, but I know everyone's also looking more forward and a more action-oriented narrative in the declaration, right? Just to give Dr. Jeff and Dr. Sonia briefly an opportunity here, if there's one thing you hope would change in the next 5 years on kidney health, what would that be? And what makes you hopeful that this can be done?
If there's one thing I hope for, it's that we stop doing business as usual. At the beginning of this month, there was an editorial by Richard Horton in The Lancet. And in that editorial, he said that the current preoccupation with primary health care condemns millions of people to disease, pain, and death. We can't keep doing this. We really need to figure out how to coordinate, how to integrate, how to work together to be able to provide high quality care at the front lines where patients first interface with us, and to be able to better coordinate all the way up to the tertiary level of care we need to provide.
Dr. Brown, maybe briefly.
Of course, briefly, I have to agree with Jeff wholeheartedly, but in my view, although money is the root of all evil, I would like to see the financing expanded, and that extrapolates to every area in the NCDs. We need to build the capacity, at least locally on island with the primary care. The primary care definitely needs to be built out. The hospital right now is inundated with cases that if we had caught them earlier, if the primary care were built out effectively, would not have got to that stage. We need the insurance. This is all money. I'm trying to get in some points. Our insurance agencies to cooperate with us and ensure we have a national insurance scheme here. This is open to every Barbadian wants to contribute to it. But we need the private sector to get on board. More conversation around finance. Finance, we can increase the outreach. We can we have a school meals program. We can put more resources into that. Community education, follow-up of these patients, and the list goes on. So in essence, I would like to see the financing, especially as a small island development country, to be improved.
Of course, financing is very, very much important, not just on this discussion and across all of the discussions this week on health, on climate, and others. We have a Q&A session, so please be ready with some of your questions if you have some. But I'd like to start with Dr. Anselm Hennis, Director of the Department of NCDs and Mental Health at PAHO. Oh, Dr. Anselm.
Thank you so much. So really, we have heard that chronic kidney disease is the end stage of unmanaged and untreated hypertension and diabetes. We've heard that most of the cases are low and middle income countries. And we also know that the vast majority of patients are disproportionately burdened those who have low social determinants of health. So my question is, how is one going to improve the diagnosis and the management at primary, secondary, and tertiary, the integrated healthcare model with an equity focus? And that's particularly troubled by what I heard from Minister Brown of Barbados. That's where I practiced medicine for many, many years. So how does one look at the problems with an equity lens?
Anyone would like to take a stab on that?
Yeah, I can try. No, I think as I mentioned earlier, is to understand also where the intervention across a continuum of care need to sit and how, in terms of resource allocation, of course, there are some difficult decisions for some of the countries, but we are talking about also very low-cost intervention for hypertension, diabetes in particular. People stay sometimes at the primary care level for 10, 15 years, treated but not controlled. And they progress until they have dialysis, until they fall to transplantation. So from an equity perspective as well, is the quality of care that could be made affordable for those people, even at the primary care level. And this is cut across all people that are at the first point of contact. It's not to have a specific focus on, of course, vulnerable population need to have the financial protection to be able to be treated for hypertension, diabetes. This brings inequity in itself because it requires that we really focus on improving the quality, the service coverage for all, and making sure that when people are progressing, they are referred. Unfortunately, most of the cases, probably 70 to 80% of the cases that we are related to hypertension and diabetes, get totally uncontrolled until they reach end stage. And this is actually something that is really an immoral condition that we need to address as a priority. Of course, then you have specific element for more vulnerable population that we know do not reach even primary care access. And this is where you need actually at the contextual level in each of the country to have other social element to be able to bring those people in treatment. But for the vast majority of the people that are already reaching out to the PHC, we have a missed opportunity that we need to address already.
Jeff or Dane, would you like, Dr. Sonia, would you like to add on that?
I'll add something. I think, particularly in terms of the equity lens, it means we really need to keep our eye on the ball. As I talked about, not doing business as usual. We know that there's a 6 million person health worker shortage in Africa as of 2030. And I've seen very little happening to invest in that problem and fix that problem. We can't deal with equity if people can't get access to the care that they need. And we need to really focus on those things. We're not going to be able to treat CKD if there's no provider at the front lines of care to see them.
Dr. Sonia, would like to add something?
Just something small apart from that. Yes, there's inequity. We have individuals or a particular class that can basically get on a plane and be treated in one of the larger countries. That is not available for many of us. We exist on a single public tertiary care institution, the Queen Elizabeth Hospital. And right now, there are about 3 doctors that look after the entire population with kidney disease. So apart from finance, the finance will also go to training. We have had some input from a few entities, universities, and some of which we are grateful for. But we need training of both specialists and in the primary care setting. I have worked primary care for some 26 years, and that is always one of the issues. Training is not, and Prof. Hennis will correct me if I'm wrong, but I don't get the sense that for instance, chronic kidney disease is on top priority of training when you come out as a young doctor. And one of the interesting things I just need to say that every group you're going, everything is priority. So kidney disease for this group is priority. Diabetes for that group is priority. It has to get to a point where we come together and realize everything is at the top shelf right now. And we need to address, but human resources and training is one of the things that we need.
Dr. Slim, are you adding something?
Oh, just to add on to what Dr. Brown has just mentioned at the end, we have been working with the International Society of Nephrology, and there was already a publication a couple of years ago on an integrated framework. It was actually, the title was on dialysis, but actually it's beyond dialysis, an integrated framework for kidney care, where actually we look not only, usually we focus on the tip of the pyramid, which is all type of replacement therapies, dialysis in particular. This is what hit the news in emergency, but also most of the time we focus on that aspect. It's important, but we need to look at the base of the pyramid in terms of primary prevention, promotion, early detection at the primary care level, and really trying to delay that progression that goes up to dialysis. And I think this is where also some of the resource allocation, the decision, the model, the colleagues from the International Society have just released also an atlas last year that was extremely important. There was a specific section on how we invest in dialysis, among other aspects, but I think this is that integrated framework for decision making that is really important, and we're really trying to have a secondary publication with ICN to be able, to put really the focus on how we built a full continuum of care, not just focusing on one aspect.
We still have some time for a question. Yes, please.
My name is Josh Goralski. I work in Haiti with unlocking communities on the basic determinants of health, such as clean water, energy efficient cooking. But kidney disease is actually a deeply personal cause to me. I donated my kidney to my dad about 15 years ago, and it extended his life by 10 years. One of the issues that since I donated, I had to literally beg the hospital system to donate because there's so much, I think, legality tied around who promotes living kidney donation, because there is an implicit risk that 1 in every so many will die during a living kidney donation. How do we, and yet donation is the key change. And until we come up with some other technology, such as an artificial kidney, what can we do to promote living kidney donation as a viable alternative to those who get to that stage with no other option? After seeing my dad on dialysis for so long, it's amazing what it did to his life for the next 10 years. Thank you.
Dr. Jeff and maybe Dr. Slim?
Yeah, I think investing in first all those points along the way to do everything we can to not get to that point, right? Because that's a very difficult place for people to be, and it is a very expensive way to deal with that problem. Is the ultimate intervention. You know, at the same time, I think that it brings me back to this point of coordinating around the system and having someone that you've worked with through that process that can be your advocate for being able to move that forward. I really think that's a critical part of this problem.
Dr. Slim, maybe something short.
Yeah, very short. I mean, it's also very dear to me because I have the same situation in my family. So I have seen both the donors and the receivers. I think it's really important to start perhaps with what you mentioned earlier, is to have the experience of lived experiences. I think we have it in cancer and survivorship. I think the transplant community, I think we need to be much more at the forefront on the NCD agenda across transplantation. Then there is ethical consideration, cultural adaptation in health systems. So it's very difficult just to discuss it with an umbrella about how donation, acceptance of donation in various countries, region, religion behave, how we work with this. I think there are multiple attempts also for WHO to issue some guidance, but I mean, the ethical dimension of donation and transplantation at large actually is something that is not moving very fast in many regions still. And there is a health system element that we discuss. I mean, transplantation requires in itself a setup that is much more complex, including the follow-up of patient, the supply chain of medication after transplantation. So all this requires also some system adaptation. It's not in 2 seconds that we will have to be able to address this, but I think the dimension about individual level system and the ethical consideration is something that need to be taken into consideration.
Well, thank you so much to our panelists. Really, we don't have much time. I'd like to thank you really for this very insightful, conversation. It's sad because when we think about global health, well, as Katie mentioned earlier, there's NCDs, there's pandemic preparedness, there's TB here. But as we've heard from this panel, really, it's all interconnected, right? But also, this very important discussion is also very personal, as we've heard from our speakers, from our audience, right? And it's also very personal to me as well. I have a family member who suffered and who's suffering from CKD. I just want to say, like, when I talk to some AIDS activists as a reporter, they often tell me how they started in their journey to become AIDS activists is because they have family and friends. They saw them dying, especially in the early days when there's no treatment yet available. And I guess you may have, some of you may have a family, a friend, someone close to you dealing with CKD, dealing with other NCDs actually. And it's tough. And I hope, that, charges everyone to, think of this more importantly, have this as a priority, whether you're working as a policymaker, you're working in civil society, you're working in all different areas of health, but see it as, not just for the NCD agenda, but also for all of the agenda. And I hope that, it charges you in some kind of activism as well, making sure that this gets a top priority in across governments. So with that, thank you so much again to our panelists. And I'd like to give the floor back to my colleague, Richard.
Thank you, Jenny, and to all of our panelists. That was a really insightful and powerful discussion. Welcome to Dr. Adira Levin, who's Professor of Medicine and Consultant Nephrologist at the University of British Columbia. And you're also past president of the International Society of Nephrology that Dr. Slamo was just referring to. Adira, welcome. We'd love to hear your thoughts on the discussions today. What caught your attention? What do you hope that our audience will take away with them? Are there any key sort of recommendations or calls to action from your perspective?
Well, first, thank you very much for all the panelists for their conversation around this and for actually heightening the awareness. And I couldn't agree more that this is really about people who have multiple health issues, and also to remind everybody that kidney disease is actually across the continuum of life. Maternal health and child exposure to infection and good nutrition all impact through the lifespan. And that, yes, kidney disease is both a consequence and a cause of hypertension, cardiovascular disease, and can amplify the problems of diabetes. And so thinking about it, as our panelists highlighted, as an integrated thing is important. There are some old studies where people went and measured a blood pressure and dipped urine, and if it had a little bit of protein, just gave them a pill to lower the blood pressure and saved lives. There are things that we can do with different, in this time, with better technology, we should be able to address this problem. I would almost see kidney disease as the canary in the coal mine. If you can find people with a little bit of protein in their urine, you might actually see what other conditions they have. And what's nice is, as many have mentioned, the way that we address this is with early identification, but the medications that are required are similar for all these diseases, and they are effective and they can be used. And I think it's important to recognize for all the people that are talking about kidney failure and the need for dialysis and transplantation, that the cost of that is so enormously higher than the cost of investing in early identification and preventive therapies, that surely must be a good argument for governments. Also remembering that in lower middle income countries, this is affecting younger people, which are your workforce. And so it becomes very circular. And I guess lastly, in the context of environmental and climate change, to remember importantly that kidney disease dialysis especially contributes to a huge amount of waste and global emissions. And climate change impacts the prevalence and the incidence of kidney disease. And so it's very bidirectional. And so thinking about kidney disease as perhaps the thing that if we could address would actually give us hope, because you can see the impact of some of these investments much more quickly if one can look at kidney disease. And I think importantly, data, as can be obtained from the Global Kidney Health Atlas that Dr. Slim mentioned, is really important. And we've done this now 3 times. And it's interesting to see what is and isn't available. As mentioned, not everybody can even measure a creatinine in a urine. Many places don't have blood pressure cuffs. These are small things to invest in. And workforce is changing dramatically, but addressing children, women, maternal health, nutrition is the fundamental, making sure we can actually test and then give access in an equitable way to simple medicines, and then foster this integrated system, I think is really important. And so I thank the panel for all of their conversation, but also data by itself doesn't fix things. You have to use it, and then it becomes information, and the root of information is to inform.
Dr. Adira, thank you very much for that. Well, now it just remains for me to thank our partners, AstraZeneca, all of our guest speakers today, and you, our attendees here in New York and online around the world. Coming up next for both our in-person and online audience from 2 p.m. Local time Eastern, Devex President and Editor-in-Chief Raj Kumar is hosting an event on cancer care that's entitled Accelerating Access, Delivering Equitable Care Across the Cancer Continuum. That's in partnership with MSD. And then from 3:45 Eastern, Devex Executive Vice President Alan Robbins will be hosting an event on malaria that's entitled Protecting Pregnant Women Against Malaria, Speeding Up Uptake to IPTP. That's sponsored and convened by the RBM Partnership to End Malaria. And I must also give a plug, tomorrow and Thursday, we're going to be bringing you a whole host of programming from our Devex at UNGA 78 Summit, as well as a series of side events. So for our online audience, I hope you've enjoyed this discussion wherever you're tuning in from. And for our in-person audience here, stand by as we bring you some remarks from a special guest after this short video from our partner, AstraZeneca. Thank you very much, everyone.
Today, an estimated 850 million people live with chronic kidney disease. That's 1.5 times the size of diabetes and 1.6 times that of cardiovascular disease. In some countries, it is a leading cause of catastrophic healthcare expenditure, with treatment cost as much as $100,000 per patient per year. Yet, for the millions affected, their story is one of adversity. Many go unrecognized and undiagnosed, and many are at greater risk of cardiovascular issues, including heart failure. However, with early screening and intervention, we can rewrite their story. We can keep people healthy, slowing disease progression, keep them out of hospital, and reduce the burden on healthcare systems. Keep them in work, contributing to society, and minimize the impact on our planet, reducing carbon emissions and fresh water use needed for dialysis. By acting on chronic kidney disease, you have the power to write more than health policies. You have the power to rewrite lives.